My name is Charles Jordan. I'm an orthopedic traumatologist in Miami, and I'd like to talk to you guys today about my experience with FibuLock. I'm going to present to you a case that every single orthopedic surgeon everywhere sees from time to time, and it's a trimalleolar ankle fracture in an elderly patient who really needs their mobility back. The patient we're going to discuss today is a 70-year-old lady who is a community ambulator. She uses a walker for support almost all the time. She fell, unfortunately, in her home, twisted her ankle, and came to the emergency room with a trimalleolar ankle fracture. It was displaced, it was comminuted. She was promptly reduced and splinted and admitted to the hospital for optimization. This is a patient who has several comorbidities, including diabetes and atherosclerosis. She has a bad combination for soft tissue complications, and this is a fracture where we would have waited several days, even sometimes a week or two, in order to be able to fix. All the while, this lady who's dependent on a walker would have begun to atrophy and weaken, and her mobility would be compromised. We were able to rather take her to the operating room on hospital day number 1. We fixed her fibula through a percutaneous incision using a FibuLock intramedullary nail, and we fixed her medial malleolus with 2 cannulated compression screws. She had overall 3 small percutaneous incisions, 2 on the lateral side, 1 on the medial side. Her syndesmosis was stable, and she did quite well after the operating room. Her ankle was stable, and we made the decision, because of her need for early mobilization, to make her weight bearing as tolerated from postoperative day number 1. She was placed in a cam walker boot, she received physical therapy, and she began to take steps out of bed to a chair on postoperative day number 1. She was able to mobilize quickly. She was able to resume normal activities within a week or 2 of her surgery, and she went on at 3 months. The x-rays I'm showing you demonstrate her fracture completely healed. Her alignment was within acceptable limits, and she didn't go through the 4, 6, 8 weeks of non-weight bearing that traditionally we've had to apply to these patients. The beauty of this as well is that it's an intramedullary load-sharing device. My experiences in treating elderly or otherwise higher risk patients in this manner has allowed me to evolve and start applying these techniques to patients who are younger, healthier, or even have higher energy ankle fractures. And this has allowed them to increase their weight bearing and their strengthening earlier.